I'm Dr. Mufaddal Kazi from Tata Memorial Hospital, and welcome to SFS. For those who are logging on to the app or the webinar for the first time, please become a member of SFS and download the app. And you can follow SFS as well as Indepso on Twitter, that's X, LinkedIn, Instagram, and Facebook. Uh, like I said, today is the second in series of the joint SFS and Indepso collaboration. The first one was on gastric cancer peritoneal metastasis, and today is on ovarian cancers. And I'm very happy to introduce Dr. Aruna, who is the clinical head of surgical oncology at Thangaram Cancer Institute and is our educational head at the INDEPSO, which is the Indian Network for Development of Peritoneal Surface Malignancies. She will be introducing the topic and the moderators. Over to you, Dr. Aruna. Thank you.
So good evening, everybody. Thank you, Dr. Kazi, for starting this session. And to introduce Dr. Snita, she's an experienced surgical oncologist working in the western part of the country in and around Pune. She's a senior consultant at the Apollo Group of Hospitals in Pune. She has a lot of experience in managing various peritoneal surface malignancies and advanced gynecological and gastrointestinal cancers. Similarly, Dr. Neha is a senior consultant gynec oncologist working in the northern part of the country. She is presently the senior consultant in Faridabad and Fortis Hospital, and both of them have authored several international and national publications on various aspects of peritoneal surface malignancies. Also worked on the making the consensus guidelines from the country on managing advanced epithelial ovarian cancers. Over to you, Dr. Snita and Dr. Neha. They will be discussing about primary versus interval cytoreduction, the various aspects from the speakers. Yeah, over to you.
Good evening, everyone. And thank you very much for the invitation and the opportunity to be a part of this session. So to move on, in 2026, I think with the publication of the recent publication of the Trust and the Surova studies, the question does remain that is primary cytoreduction still the default standard, or has interval cytoreduction become equally acceptable in routine practice? And is the debate truly about timing of surgery or about achieving complete cytoreduction regardless of sequence? And should treatment strategy perhaps be center-driven, surgeon-driven, or biology-driven? And what are the criteria to select patients for and in which sequence? So today we have two very eminent speakers who are going to throw light on the management of advanced ovarian cancers. And it gives me immense pleasure to first introduce Dr. Anuradha Chandramohan. She is the Professor of Radiology and Clinical Lead of Abdominal Radiology at CMC Vellore, and she is going to enlighten us with the various aspects of radiological diagnosis of advanced ovarian cancers. Over to you, madam. Thank you so much.
Thank you very much, Dr. Sinta, and thank you very much, Dr. Aruna, for having me here. I'll just share my screen and move on to my presentation. And it's indeed a great privilege to be a part of this forum. I hope you're able to see my screen. I'm just going to move to slideshow.
Since you have paused the screen share.
Yeah. So very good evening, everybody from India and all over the world. And it's my real privilege to be a part of this wonderful platform of which stands for sharing knowledge and expertise among the surgeons. So in this presentation, what I want to touch upon is the preoperative radiological predictors of surgical outcome in advanced ovarian cancer, and what would be the criteria for primary and interval cytoreduction. So we know in India, ovarian cancer is the third most common gynecological cancer, and the incidence is slowly increasing. And as of 25-26 in India, we had about approximately 50,000 new ovarian cancer patients. And
I'm
ovarian
really
cancer.
sorry, madam, to
Yeah.
interrupt you. We are unable to see a screen because the message shows that you have paused your screen sharing.
Oh,
So
okay. I'm so sorry. Let me just take care of that. I'm gonna stop share and do it again. I'm sorry for the interruption. That should. Are we good now?
no, still unable to see your slides. Yeah, now we are good, madam. Yeah, we are good to go.
Yeah, good. Yeah.
Okay, thank you very much. And ovarian cancer, as I said, very high incidence in India. It's not a high incidence proportion because our population is so high. We at least have 50,000 new cases every year. And all radiologists, practicing radiologists, we would see a few cases of ovarian cancer wherever we are practicing. And it is a disease with high mortality. And most patients with ovarian cancer present late. And in India, about 60 to 80% of them would present with FIGO 3 and 4 disease, but that is the same everywhere. And majority of them would be epithelial ovarian cancer. High-grade serous is the most common. I mentioned this fact because the imaging appearance of low-grade and high-grade can be differentiated on imaging with the help of you can look for presence of calcification and then decide on whether a particular patient might be a low grade or a high grade. And radiologists could actually suggest this possibility, which would be one of the important points that must be discussed in the MDT. For example, in this particular image, this is an image of a 65-year-old female patient. And she has a large volume peritoneal disease, as we can see in this image. There's also bowel involvement, tomental caking, large masses in the pelvis. And she had high-grade serous ovarian cancer. And this is mostly soft tissue density masses in the peritoneal cavity, and there is no calcification. And these kind of tumors are very platinum sensitive, but they have a poorer prognosis. Whereas, on the other hand, a low-grade serous ovarian cancer usually is seen in a younger patient, and these masses show distinct calcifications in at least nearly 20% of patients will have calcifications. So when we see calcified masses in the peritoneal cavity, it is good to mention this in the report and convey this finding to the surgeon, because these patients, in spite of a large volume peritoneal disease, they will not respond to chemotherapy, and surgery might be required to treat these patients. So what is the contribution of imaging? The contribution of imaging is to staged ovarian cancer patients, to support the MDT and provide a platform for surgical triage. And also it is a very good surgical roadmap, and imaging helps also in surveillance of the patients. So in this presentation, I hope to touch upon imaging modality and protocol, the structured imaging framework that can help surgical decision making, and I want to share some results from our own experience. So CT remains the first preferred imaging modality, and it has to be a contrast-enhanced CT of the thorax, abdomen, pelvis in any patient suspected to have primary epithelial ovarian cancer. And in our center, we use a split bolus technique to delineate the course of the ureter in all these women, because it helps the surgeon who's doing cytoreductive surgery when they know the course of the ureter. And we always also give positive oral contrast in our center because it helps us delineate small mesenteric and serosal disease better. So this is our protocol for the CT. We use MRI sparingly, though it is superior in accuracy compared to CT for assessing peritoneal spread, but it is all driven by the expertise available for image acquisition and reading in different centers. And it is not a part of our routine staging or MDT workflow where we are still trying to decide whether the patient should undergo surgery or neoadjuvant chemotherapy. But we use MRI sparingly in select situations to identify disease in hidden areas where laparoscopy is incomplete. And we also use we use MRI as a preoperative imaging tool to map the disease and to facilitate a surgical planning. But having said that, MRI is not very good in differentiating fibrosis from residual tumor, especially after neoadjuvant chemotherapy. And even MRI can, similar to CT, can miss small nodules smaller than 5 millimeters. And this is a problem with all imaging modalities. FAPI PET is a new toy in the block, but then is a new modality that is available for our use. But then FAPI PET is not really established. The evidence is still evolving, and we do not know how it will perform when it comes to fibrosis, inflammation, small nodules. We know PET as such is not a suitable imaging modality to image structures that are smaller than 1 centimeter. And this is an example to show you how MRI could pick up the subtle plaque-like peritoneal nodule along the anterior surface of the liver, and could also pick up this nodular disease near the Morrison's pouch, and could beautifully delineate these mesenteric nodules, which could have been a little hard on CT, where we are trying to differentiate lymph node versus mesenteric disease. So the MDT support or MDT decision support with imaging is through using a structured reporting framework. In our center, we use PAUSE as a framework, where P stands for the primary and the radiological PCI, A stands for ascites and abdominal wall disease, U for unfavorable sites, S for mesenteric and small bowel disease, and E for extraperitoneal disease. I'll show you, there are also other frameworks that can be used in different centers. And for example, PROMISE is one of the tools, Simplified PCI, Fagoti, Bumpy, and ESMO-ESGO resectability criteria. These are all different frameworks that are available, and we can choose from one of these. In this presentation, I'm going to take you through PAUSE. So let's see what are the components that we need to look under P. Under the P component, we need to answer these questions. Is it a primary ovarian cancer? What is the FIGO stage? How are the planes with few critical structures like rectum, sigmoid, colon, ureters, and the iliac vessels? And what is the volume of peritoneal disease in this patient? The first question to answer is it actually a primary ovarian tumor? And this is, I'm showing you two different examples of Krukenberg's tumor, both from stomach. And we're seeing solid bilateral ovarian masses, which is the most common. 80% would be bilateral, 80% would be solid. And these are the primaries that we need to think of when we see solid bilateral ovarian masses with this morphology. On the other hand, Krukenberg's tumors could also be cystic in 20% of patients. They can also be unilateral. When we see cystic Krukenberg's tumor, you must consider colorectal primary, appendicular primary, or a biliary tree primary. There could be mimics that would mimic epithelial ovarian cancer, like primary peritoneal carcinomatosis, where the primary itself is really small, but the peritoneal disease is disproportionate, usually occurs in elderly patients. And when we see this kind of picture with diffuse peritoneal disease, we have to think of primary peritoneal carcinomatosis. Other mimics are pseudomyxoma peritonei, which could mimic mucinous peritoneal carcinomatosis, and multicystic mesothelioma, which we can occasionally see, where there are cystic masses that are filling the peritoneal cavity. And not to forget that gist of the bowel can also mimic ovarian cancer. Next question is, what is the Sorry. Next is the FIGO stage of the patient, where it could be most of the patients with advanced epithelial ovarian cancer would be stage 3 and 4. And I will move on from this point after saying that. But I want to emphasize that stage 4B includes inguinal lymph nodes and the cardiophrenic lymph nodes. And transmural bowel infiltration is also a FIGO 4B finding. This is an example to show you rectosigmoid colon involvement. We don't regularly use positive oral contrast, but in this patient with the positive oral contrast, we can see how the mass is encasing the sigmoid colon and is abutting the rectum. But MRI is far superior in delineating large bowel infiltration. This is an example to show you bilateral hydroureteronephrosis and to show you how split bolus works. What we do in split bolus is we give half the volume of IV contrast when the patient is waiting 10 minutes prior to the CT, and the rest of the volume is given on the table so that in the venous phase we will be able to delineate the entire length of the ureter. And this works out really well for delineating the course of the ureters in ovarian cancer patients. This is an example to show how the tumor courses very close to the external iliac vein. And let's move on to peritoneal cancer index. Peritoneal cancer index is basically a score given to the masses in the peritoneal cavity in 13 different sites as mentioned here. And based on the size of the tumor, the score is either 1, 2, or 3. But radiologists need not, I'm so sorry. I'm sorry. The radiologists need not really measure these tumors in practice. We can eyeball and actually give you PCI with practice in 5 minutes or less. And this is an example to show you thick disease in the right subphrenic space, which will get a score of 3. There are intersegmental fissural disease, left subphrenic disease, paracolic gutters, and a disease in both paracolic gutters in the lumbar region, Morrison's pouch disease, omental cake, and lower abdominal disease and pelvic disease. This is an example to show you small bowel mesenteric nodules and mesenteric fold thickening, which gives scores to regions 9 to 12 of the PCI. A cutoff of more than 13 really affects the outcome of cytoreductive surgery. So in clinical practice, it is really useful to map the peritoneal disease and provide the regions with the scores because it helps in surgical decision making. About the ascites, large volume of ascites is known to influence the outcome of the patient. And so we try to make an effort to mention large volume ascites. We don't bother about mild ascites or no ascites. And abdominal wall nodules are important because if it is a lateral abdominal wall nodule, it affects the reconstruction, abdominal wall reconstruction, and can be an unfavorable site of disease. But midline nodules can be easily dealt with. This is an example of very extensive abdominal wall disease. Even if there was no other disease within the abdomen, if a patient has such extensive abdominal wall disease, that itself may be an unfavorable site, and closing the abdomen after surgery would not be possible in such a patient. PCI alone is not enough. We always have to also talk about unfavorable sites of disease. And we've made an effort to list the unfavorable sites in different locations, epigastric region, retroperitoneum, and the pelvis. And I'll just take you through a few of them. The unfavorable sites can be classified as those that increase the complexity of surgery, or those that may completely result in cytoreductive surgery not being successful, or it might result in just a major tumor debulking. These are examples of U1 sites which increase complexity, that is a disease in the intersegmental fissures, in the lesser sac, and this is an example of disease along the lesser omentum, again, indenting the stomach, gallbladder fossa, Morrison's pouch, and disease in the gastrosplenic ligament. So these are U1 sites of disease. What is U2, where resection, R0, R1 resection is unlikely? Examples are thick diaphragmatic disease more than 2 centimeters, when there is laceromental disease causing vascular or biliary obstruction, when there is multifocal small bowel serosal disease, root of mesentery disease, small bowel obstruction that is multifocal, pelvic sidewall disease, nodes above the celiac trunk, or extraperitoneal disease. This is an example to show you a thick subphrenic disease, which is a U2 finding. And there is also omental caking and some mesenteric fold thickening in this patient. Small bowel mesenteric disease, again, if it is soft tissues in the mesentery or when there is complete loss of architecture of the mesentery, those are also unfavorable sites, which will result in incomplete cytoreduction. And these are examples to show nodules in the mesentery. This is transmural infiltration of the bowel. If it is a single site obstruction, that would just be a 4B FIGO, and it will be a U1 site, and surgery would be possible. But if it is a multifocal a bowel obstruction from bowel serosal disease, that is a unfavorable site, a U2 finding. So this is an example to show you how MRI delineates the mesenteric nodules. In this example, but the difference in the accuracy between CT and MRI is not much. It's 92% for MRI versus 85% for CT. So the strategy of using CT as an initial imaging modality and using MRI selectively is really works. But both these imaging modalities are not without pitfalls, as I mentioned earlier. Only such gross disease can be picked up on imaging, but small miliary nodules will be missed by all imaging modalities, and that is the need for laparoscopy prior to surgery. Components of POS includes liver metastasis, splenic metastasis, lymph nodes like inguinal, cardiophrenic, portal nodes, and lung metastasis. And in this example, I've tried to show you the difference between serosal disease versus metastasis. Metastasis make acute angle of contact with the liver parenchyma, whereas deposit in the peritoneum indenting the liver would make an obtuse angle of contact. Malignant pleural effusion are also extraperitoneal disease. So from our results, I just want to share our experience very quickly. This is a prospective study we did in our center on 124 patients with a FIGO 3 and 4 epithelial ovarian cancer. We used POS prior to MDT and observed the correlation between POS and MDT decisions. And our MDT's rate of complete cytoreduction during this period of study was 89.3%. And in this table, I want to highlight how all the components of POS correlated well with the MDT decision-making of surgery, primary or interval cytoreduction, neoadjuvant chemotherapy, or best supportive care, and except for abdominal wall disease and extraperitoneal disease, because the numbers were smaller compared to the other areas. But this extraperitoneal disease not correlating with the decision making is not only us, even the French group recently has published their paper, which also shows how extraperitoneal disease volume did not influence their surgical decision making and the surgical outcome. This is a nomogram based on our results where we've shown for a cutoff of 55 for post-based nomogram, there was a reasonable discriminatory power. And when we go and simplify this POS-based nomogram using only upper abdominal disease, which is a sum of PCI scores of regions 1, 2, and 3, it was actually better. So we think that in a clinic or in a quick MDT triage for decision-making, surgery versus chemotherapy kind of decision-making, this simplified nomogram using upper abdominal disease and the other components would really work. And the inter-observer agreement for these two nomograms were reasonable in our experience. And I want to conclude by saying that CT is the first imaging modality and MRI can be used as a surgical roadmap in select cases. Structured framework for communication such as pause can be used as a decision support tool. And upper abdominal disease and U2 findings on CT may be quick surgical triage tools, which can be adopted very easily. With that, I just want to finish, and I want to thank again for giving me this opportunity. And I want to again apologize for the interruptions in this presentation.
Thank you, Dr. Anuradha, madam, for this wonderful presentation. You have pretty much covered the entire nuances of imaging in ovarian malignancy. We shall take the questions after the next talk, and I would request Dr. Neha to kindly introduce our next speaker.
Good evening, everyone. It gives me immense pleasure. Sorry, too much of it. Yeah. Okay.
Dr. Neha, there are two that from. Can you please?
No. Can you hear me now? Yeah, can I go ahead?
I think in the interest of time, I'd like to take the opportunity to introduce Dr. Ann. It gives me immense pleasure to invite her to this session. Dr. Ann is a prolific speaker and a wonderful academician. She has a high interest in academics. She is the senior consultant and head of endometrial cancer and gynecologic sarcoma team at the Norwegian Radium Hospital, Oslo University Hospital. It's an absolute pleasure to have you here. And Dr. Ann, over to you.
Thank you, Dr. Snita. Thank you for the kind invitation. It seems to be an echo. Okay, hey, I think we're good now with echoes. Thank you again for having me. It's a huge honor to speak for your group here today. And you've challenged me with talking about the continuing debate of primary and interval cytoreduction. So with no further ado, I have no relevant disclosures in regards to this topic, and I'm going to start with the take-home message. And my take-home message is that the most powerful predictor of survival in advanced ovarian cancer is residual macroscopic disease after surgery, regardless of whether surgery is primary or intervals. We really need to keep in mind this powerful predictor. And with this, complete cytoreduction remains the cornerstone in managing advanced stage ovarian carcinoma, and we'll also talk about how patient selection to achieve this and the timing of surgery is key. So in regards to definitions, when we talk about cytoreduction, we talk about reducing the number of tumor cells, and our aim is complete cytoreduction, and I'll get back to why. When it comes to debulking, this is really reducing as much of the bulk of the tumor as possible. This is terminology that we've used in the past, and we're now really trying to move away from that nomenclature and to describe our surgery as cytoreduction and not debulking surgery. And in theory, this maximal surgical effort that we see has the strong prediction is that it should help overcome this intrinsic drug resistance, increase drug perfusion, enhance the host immunological response, increase the growth function of tumor cells, and also circumvent acquired drug resistance after adjuvant platinum-based and taxane-based systemic therapies. Now, I like to take an historic outlook always when I give talks, because we need to line and look back in history to understand where it is that we are today. So briefly, in doing this, and again, talking about how we've evolved as surgeons within our field and understanding the importance of complete cytoreductive surgery, this landmark paper by Griffiths and colleagues came out in 1975, and this is quite a few years ago. But already then they saw that size of residual tumor was the most important factor for survival in advanced stage ovarian carcinoma. Then they just looked at various sizes. Now, if you fast forward 20 years to 1994, we thought that optimal debulking, which was the terminology used at the time, was residual disease equal to or less than 2 centimeters. And you see in this paper here from Dr. Hoskins and colleagues in 1994 that the 5-year survival of the patients who had microscopic residual disease was 60%, compared to those that had more than 2 centimeters residual disease was less than 20%. So clearly a significant difference in survival here. Fast forward another 20 years to 2006, we had several publications, and these are all retrospective single center publications. And this is from Dennis Chi and colleagues at Memorial Sloan Kettering Cancer Center in New York, as was the paper by Hoskins. And there we thought that residual disease, so optimal debulking, was residual disease less than 1 centimeter. And you see here that the median overall survival for microscopic residual is 106 months. And the middle group here, less than 5 millimeters, and from 5 to 10 millimeters is 66 and 48, whereas those who have more residual than 1 centimeter do much worse in regards to outcomes. And since then, we've said that complete cytoreductive surgery is what we aim for, which is no residual, and that optimal cytoreductive surgery, so equal to or less than 1 centimeter, can also be acceptable, particularly for certain subtypes. And we'll get back to that in regards to also the previous talk where we differentiated between low-grade serous and high-grade serous, and that would be, for instance, a clinical scenario. We would take that into consideration. Also in 2006, we saw this retrospective review. So I said that these were single center retrospective studies, but then the GOG put together patient populations from 6 different GOG studies looking at adjuvant chemotherapy after surgery, and also then looked at surgical characteristics. And they saw that in this group of almost 2,000 patients, cytoreduction to more than 1 centimeter residual had no benefit on overall survival. There was a survival benefit associated with less than 1, whereas gross residual or microscope, so no gross residual, had the highest survival. And you see this in the bottom here, median overall survival almost 72 months, which is the highest in this group. Up until then, G1 oncologists, we were thought to be pelvic surgeons. We did pelvic cytoreduction because we were defined historically by radical hysterectomies and cervical cancer. This was really the cornerstone of what we did in the OR. And in many places, cytoreductive surgery also was limited to the pelvis, even with low transverse abdominal resections and not even midline resections. And for us today, this is maybe strange to think about, but this is really how our field has evolved. And we know that ovarian cancer doesn't just stay in the pelvis, it goes to the upper abdomen, it's in all quadrants, and even in the chest. We all now resect cardiophrenic lymph nodes and even pleural disease for women with advanced stage ovarian cancer. So there was a paradigm shift in the early 2000s where we turned and started to look in the upper abdomen. And as you see, these are examples of disease that we see very frequently with advanced ovarian cancer and carcinomatosis in all quadrants. This again is a publication by Chi and colleagues from 2009, where they compared a group. So the red line here is a group they underwent surgery in 1996 to 98, so a long time ago, where upper abdominal surgery was not incorporated. And then you look at group 2, which was a more recent cohort where upper abdominal surgery was done, splenectomies, distal pancreatectomies, diaphragm, peritonectomies, procedures that we use today. And this group had a significantly longer median overall survival. So we know that this is what we're aiming for, and this is the basis of what we do. In addition to this, we know that this surgery needs to be done at expert centers. So this is a study from Norway from my colleague Torbjørn Paulsen. Well, he looked at teaching hospitals as the blue line and non-teaching hospitals as the red line, and showed a significant difference in survival when patients were operated at centers with high volume and teaching hospitals. And this has been repeated in multiple settings after this. This was again in 2006. Another study, a meta-analysis by Bristow and colleagues, showed this, that expert versus less experienced centers, so less experienced, they had less than 25% maximal cytoreduction. The median overall survival there was 23 months compared to centers that had more than 75% maximal cytoreduction, and the median OS was almost 34 months. And that's not enough. We also need expert surgeons to do these surgeries. Alati and colleagues looked at this at the Mayo Clinic and compared surgeons who frequently performed radical procedures. So if you as a surgeon do a radical procedure in more than 70% of your cases, they were compared with colleagues who did radical procedures in less than 40% of cases, and again showed that when these expert surgeons, when patients were operated on by them, correcting for other factors, there was a difference in survival. So based on this ESGO, as we try to harmonize care for women with GYN cancers, we have quality indicators for also ovarian cancer surgery. These will be updated after we publish our updated guidelines. That's our first job, and then we will update these quality indicators, but we take into account here rate of complete surgical resection, but also number of cases, not only per center, but also per surgeon. And this is very, very important. We're very proud of all our accredited centers. We accredit centers based on our quality indicators. I know we have centers in India that have then joined us because we formed a consortium of accredited centers to further explore and create the ESGO database. The first database is on patients with advanced stage ovarian cancer. And I'm going to show you a few of these results before we go into the randomized trials on primary versus interval cytoreductive surgery. And in the ovarian cancer database, we have patients operated on at these centers from January 1st, 2020 until December 31st, 2022. And our main outcome was really to evaluate the quality indicators, but it's also a database that can do so much more than just that. We have more patients than this now, but our first analysis had 10,500 patients, and you see here that 45% of the newly diagnosed cases underwent upfront cytoreductive surgery, 42% interval cytoreductive surgery, and 13% never made it to the OR. This is in stark contrast to national data, both from the UK and Norway that I'm familiar with, where almost 40% of patients actually in a national system, even if it's centralized, does not make it to the OR for these cases. So these are highly selected patients. We just need to keep that in mind. These are the patient characteristics. And again, you see that ECOG, they have higher ECOG when they undergo interval cytoreductive surgery compared to upfront cytoreductive surgery. And also the women who never make it to the OR are much more frail, and they also have a higher FIGO stage. In regards to surgical characteristics, and we're going to get back to this, we see that 40% in the upfront cytoreductive surgery group and 26% in the interval cytoreductive group have high surgical complexity score, and also 47 and 43% have intermediate. So these women have all undergone extensive cytoreductive surgery, and that's why complete gross resection is achieved in as many as 85% at upfront cytoreductive surgery and 81% at interval cytoreductive surgery. Systemic therapy, we're going to skip that for now. And I just wanted to show you this preliminary graph in regards to progression-free survival in this cohort. So the bottom line is the green line are women who didn't undergo surgery at all, and they do the poorest. And at the top, the light blue line, they underwent upfront cytoreductive surgery with no residual disease. and the progression-free survival at 24 months is 63%. And then the interesting lines are the two in the middle, the light green, which is interval cytoreductive surgery and no residual, compared to upfront with some residual disease. So in this graph, we have not explored the amount of residual disease. So we don't know, or we haven't looked into in this graph, these are all comers, so they have any residual disease, so they could also have significant. So this is future work that we will be looking into. But this just again states the importance of upfront cytoreductive surgery with no residual disease for patients who can tolerate that and are amenable to this. And that's why the previous ESGO guidelines, the first question that we ask in our algorithm is surgical skill available? If no, send the patient to a multidisciplinary unit with surgery meeting the ESGO quality indicators, and do not just automatically use neoadjuvant chemotherapy, because we want these women to be evaluated by experts to see what their management strategy should be. So let's get back to the randomized trials in regards to upfront versus interval cytoreductive surgery. So we all know during our multidisciplinary team meetings, and when we see these women, we want to see what should be the order of therapy. So traditionally, we've used cytoreductive surgery followed by 6 cycles of adjuvant chemotherapy. Carboplatin paclitaxel is our standard of care. AUC 5 or 6 for the carboplatin, and the paclitaxel 175 milligrams per meter square. However, we have the option of giving neoadjuvant chemotherapy. We would then typically give 3 cycles of carboplatin paclitaxel. The woman would then undergo cytoreductive surgery with an additional 3 cycles. I am not going to go into the chrono trial, but the chrono trial is exploring number of cycles of neoadjuvant chemotherapy. And as far as I know, this will be published or presented at ASCO now in 2026 this summer. So we're excited for the results from the chrono trial to inform us if the number of neoadjuvant chemotherapy cycles, currently set to 3, maybe 4, some centers, is correct, or if it could be increased. So these 2 landmark trials, the EORTC and CHORUS trials, were published in 2010 and 2015. They involved patients with stage 3-4 high-grade ovarian carcinoma, and patients were randomized to upfront surgery versus neoadjuvant chemotherapy. Both of these trials were non-inferiority trials. So we should just keep that in mind. And the reason I'm saying that is we're going to get back to the TRUST trial and also the SCORPION trial, and they were superiority trials. So they're powered or set up differently. So looking at the EORTC trial, the progression-free survival for women undergoing primary cytoreductive surgery was 12 months, and that was exactly the same also for women undergoing neoadjuvant chemotherapy. In regards to overall survival, also you see here similar survival, 29 months and 30 months in these groups. The CHORUS trial 5 years later, again, we did not see a difference between primary cytoreductive surgery and neoadjuvant chemotherapy. No difference here that was significant in regards to hazard ratios. And both these trials, when you pooled the individual patient data, we saw similar survival between the treatment groups. And we also saw that there was an improved rate of optimal cytoreduction, so rejection rate with the neoadjuvant chemotherapy, and there were less adverse events when using neoadjuvant chemotherapy. But as I'm sure you know, both of these trials have been heavily criticized. And one of the reasons why these have been criticized is because we've looked at the quality of surgery in both arms in both these trials. And I've put them together here and also added the SCORPION trial, which is a single center trial done at Gemelli in Rome, where women with also advanced stage of ovarian cancer, but we have to keep in mind also that in the SCORPION trial, they only looked at patients with a large tumor burden. So they didn't include women that did not have a very high tumor burden, and also they performed, as they do at Gemelli, according to the Fagotti score, a laparoscopic evaluation, and then women who were deemed amenable for cytoreductive surgery were randomized either to primary cytoreduction or neoadjuvant chemotherapy. And if you look here at the bowel resection rates, for instance, very low in EORTC and chorus, and then compared to the Scorpion trial. The complete resection rates also very low, and these are in the upfront arm. So the upfront arm in EORTC and chorus, 19 and 17% compared to 42% in the Scorpion trial. Median duration of surgery, again, very low in the EORTC chorus, in the upfront arm. So this is not after neoadjuvant chemotherapy. This is the upfront surgery, median OR times of 165 and 120 minutes, comparable then to the Scorpion trial, 460. The postoperative mortality was lower in these trials, but again, this is the upfront arm, and there's not that much difference in progression-free survival. However, there is a large difference in median overall survival. And as a caveat, though, if you look at the EORTC trial, if there was no residual disease, the median overall survival was significantly higher. And we'll get back to this table, and I've added some results from the TRUST trial that we'll look at in a couple of slides. I also wanted to compare this, and one of the reasons, we critiqued this so heavily when they came out, because the numbers that we had to compare with were these large single institution centers. And you look at that MSK cohort that I showed you in the previous slide with median overall survival, no residual, of 83 months compared to 45 months in the EORTC with primary cytoreductive surgery and 38 after neoadjuvant chemotherapy. So as surgeons, we were really questioning these trials and the generalizability of these, and were these really just patients who either were poor performers or had been selected badly, or was it that the quality of surgery that was done here was subpar? So then came the TRUST study. And the TRUST study is, as I said, a superiority trial, so it's not a non-inferiority trial, also comparing primary cytoreductive surgery to neoadjuvant chemotherapy followed by interval cytoreductive surgery. The TRUST trial used the ESGO quality indicators as a basis when they selected institutions that were allowed to participate in this trial to ensure a very rigid inclusion of centers having a high quality of surgery, good infrastructure, so that this study would not receive that same criticism as we saw in EORTC and chorus. The primary endpoint for this was overall survival, and they had key secondary endpoints which were progression-free survival, complete resection rates, surgical procedure, surgical morbidity, and also quality of life. And they also had predefined exploratory and translational endpoints. And as you know, this study has yet not been published, but it was presented at ASCO last summer. And these are some of the slides that Svein Mahner showed at ASCO. So they enrolled patients quickly from August 2016 to June 2019, almost 800 patients that were equally randomized to one arm or the other. And their intention to treat analysis population is just under 350 patients in each arm. Now, just looking at systemic therapy, because I'll jump back into the surgical criteria in a table that I've generated. First-line chemotherapy was given to the majority of patients. Bevacizumab was given to around 60% in both arms, and PARP inhibitors were also given. Obviously, patients in the EORTC and chorus trials did not receive this. In Scorpion, a high number, similar to this, did receive bevacizumab maintenance therapy. Now, in the intention to treat the population, looking at progression-free survival, we see that there is a significant difference between primary cytoreductive surgery and neoadjuvant chemotherapy group, with the median PFS of 22 months after primary cytoreductive surgery and 19.7 months after neoadjuvant chemotherapy. Is this clinically meaningful? A difference in less than 3 months. That is up for debate, but it's certainly something that we should ask ourselves. moving to the overall survival, and this was their primary endpoint, and the study was negative for this in the entire population. So for all comers, the median overall survival for primary cytoreductive surgery was 54 months, and after neoadjuvant chemotherapy, 48 months. I would say this is numerically a larger difference than the progression-free survival, so possibly clinically more meaningful, but it did not reach statistical significance. This is half a year, so 6 months difference here. So if you put the numbers from the TRUST trial into that table that I showed you earlier from the EORTC, Chorus, and Scorpion trials, we see some significant differences. So for instance, looking at the bowel resection rates, which were 15 and 11%, remember at the upfront arms in EORTC and Chorus, they were 84% in the upfront arm in Scorpion, and I added, so it's 18.9% in the neoadjuvant arm in Scorpion. And if you look at the TRUST trial again, many women had bowel resection, 68% at primary cytoreductive surgery and 38% after neoadjuvant chemotherapy. Again, looking at complete resection rate, and I told you early on, and really this is the key take-home message here, that complete resection is the most important prognostic factor, and this is what we need to achieve, whether it's at primary cytoreductive surgery or at interval, and we need to select our patients well, but this is really where the money is for these women with this disease that we're looking after. And in the TRUST trial, at primary cytoreductive surgery, it was 68%, at interval 79%, and tremendous difference clearly from the EORTC and Chorus trials, which is one of the main reasons why these women do so much better. Median time in the OR, significantly longer in TRUST than EORTC and Chorus. Postoperative mortality at 28 days was very low in TRUST. So despite a huge surgery, large resections, there was no increase in postoperative mortality. And then the median progression-free survival, again, significantly longer, 10 months more in TRUST than EORTC, and also for the interval cytoreductive surgery group. Median overall survival also 54 in the months in the upfront arm in TRUST compared to 29 in EORTC, with the caveat, of course, that a large number of patients, or large proportion even in TRUST, did receive bevacizumab and PARP or PARP as maintenance therapy. I mentioned that the TRUST trial had some pre-specified exploratory subgroup analysis. One of them was looking at patients with stage 3 disease. We know that stage 3 and stage 4 behave differently. There's also differences within stage 4. But here, looking at that predefined exploratory subgroup analysis of FIGO stage 3, we see that there is a statistically, and I would also say clinically meaningful difference between primary cytoreductive surgery for PFS, 26 months compared to 21 months for neoadjuvant chemotherapy. And for overall survival, again, they did not meet that primary endpoint here of statistically significant, but again, it is clinically significant, at least in my book. The median overall survival after primary cytoreductive surgery is 63 months, which is 10 months more than after neoadjuvant chemotherapy, where it's 53 months. They also had a pre-specified subgroup analysis in regards to complete gross resection. And we see again for primary cytoreductive surgery for the PFS, 28 months compared to 21.8. So let's say 28 compared to 22 months. So that's 6 months difference in progression-free survival. And for overall survival, they did p-value of 0.0521. But again, if you look at primary cytoreductive surgery, overall survival, if complete gross resection, of 67 months compared to 55 months after neoadjuvant chemotherapy. Looking at the subgroup analysis here, and what is it that shows up on this forest plot as being statistically significant and in favor of primary cytoreductive surgery? Well, it's having FIGO stage 3, ECOG or age over 65 just doesn't meet significance. Complete gross resection, however, does. And this is for progression-free survival. And looking at overall survival, we can see that the only factor really that is possibly significant, even though it just crosses one, is complete gross resection with the hazard ratio of 0.8. I showed you this already in regards to surgical morbidity, which was acceptable for both groups and not that different. And in regards to quality of life, this was also the same for patients in both cohorts. So these are the conclusions from the trust group themselves, that they did not meet their primary endpoint of a statistically significant overall survival. But it is, however, the first randomized phase 3 trial to show a benefit in median progression-free survival for primary over-interval cytoreductive surgery without compromising short or long-term quality of life, which is very important, obviously, for these patients. And that the observed benefits were linked to complete resection rates, and also that the high rate of complete cytoreduction with low morbidity and mortality, along with the excellent PFS and OS, emphasize the importance of surgery quality assurance programs. And this is a challenge. And why is this a challenge? So there's an increased use of neoadjuvant chemotherapy within our community based on the EORTC and CHORUS trials. We have new systemic therapies. We have evolving non-surgical approaches to managing complications such as obstructions and fistulas. And this is all good for our patients. And also there's then these disincentives for radical surgery, particularly in countries where this is driven by financial incentives. So this is true for some parts of the world. And what this results in is that our graduates, our fellows, are not necessarily feel well prepared to perform these radical procedures that we need. So whether we're going to do primary cytoreductive surgery or interval cytoreductive surgery, we still need to be proficient surgeons. And this is something that us as a community, we really need to take seriously, because as was shown in the TRUST trial, and I'm showing here also a retrospective study, again from MSK, high surgical complexity is needed also after neoadjuvant chemotherapy. So in this historic cohort, complete gross resection was achieved in 76% at primary cytoreductive surgery and 71% after neoadjuvant chemotherapy. And this is almost 1,000 patients in this study. And you can see here the type of procedures that were used. And if we look at the larger bars, they're easier to read and there's fewer of them, and the frequency of procedures performed. So primary cytoreductive surgery is the dark blue and interval cytoreductive surgery is a light blue. We still see that bowel resections, upper abdominal procedures, and any radical procedure is very frequently used after neoadjuvant chemotherapy. So upper abdominal procedures was done in more than 50% of women after neoadjuvant chemotherapy. And we also saw this as in the ESGO database. So there have been some previous studies that have suggested, obviously, that biology makes a difference, and it really does. But some have suggested that if you perform radical and complex surgery, biology might still trump that, and you cannot achieve good outcome. And we do know that we have limited follow-up on these patients, but still we show here very, very nicely, and you see all these graphs in blue are women who underwent surgery and had no residual disease. So whether they had low, which is dark blue, surgical complexity score, medium surgical complexity score is the lighter blue, and then the lightest blue is a high surgical complexity score. And yes, the ones with the highest surgical complexity, they do worse than those with the low surgical complexity, but this is likely because they have more disease and possibly a higher stage. This is all stages, but they still do significantly better with those that have residual disease. So doing complex surgery to achieve no residual makes a difference in regards to progression-free survival, whether compared to if you leave disease behind. Just a few words on patient selection. This is again a guideline from the European Society of Geo-Oncology, and we will be working on updating this again. But in this, we say that preoperative considerations in regards to disease, of course, are very, very important, but we also have to remember to evaluate patient status. And there's good data, particularly from the Mayo Clinic, led by Bill Kleiby and his colleagues. They have several publications on triaging patients for this. And we should screen and assess nutritional status. We should look at frailty. There are multiple tools in assessing frailty, providing psycho-oncological support, and also patient education. And this quotation at the bottom here is actually my father's geriatrician. When we went to see him once, he said to us that age is just a number, but until it catches up to you. And when age does catch up to you, these patients have much more limited resources biologically. So if we do radical procedures, we really have to be mindful that the women will tolerate this. And this is also why question 2 or point 2 in the previous ESGO guidelines was, is the patient fit for extended radical surgery? And if she is not, we should consider neoadjuvant chemotherapy or palliation. We've just presented the new ovarian cancer guidelines, and these are my final slides here. I'm sorry if I'm running over. I just wanted to bring your attention to the updated guidelines. We're working on submission of these guidelines now and finalizing them. We had a huge representation, more than 300 external reviewers globally. So we feel that these guidelines, although they come from us at ESGO, they really have global representation. And this is, I wanted to share with you one of our algorithms in regards to workup, which is, I believe, in line with the previous talk. I'm not going to go through this in detail. We do say that primary treatment should be primary or interval cytoreductive surgery, which should result in total macroscopic tumor clearance, both intra-abdominally and extra-abdominally. And we also encourage a structured operative report, including at least the size and location of disease at initial exploration of the abdominal cavity and at the end of surgery. And we encourage the use of the ESGO op report. And I really encourage you to download this if you don't use it, or maybe you have another one in your institution, but we've updated this as well and we'll be publishing the new. But it's really important. It helps us as surgeons, I think, to be systematic. And so if we systematically register what our findings are at the beginning of surgery and also at the end of surgery, and what's the residual and why were we unable to resect certain portions if that's the case. This just helps us being structured in our approach to our patients. In regards to neoadjuvant therapy, these are our recommendations here. Again, in the interest of time, I'm not going to go through them in detail. And then I think this is most interesting for our community, that in these guidelines, we've made new tables and figures, and we've divided here, we've split stage 3 and stage 4 into 2 different tables. So our indications for primary cytoreductive surgery in stage 3 disease, you can see the red here is in poor performance or nutritional status. We do recommend going to neoadjuvant chemotherapy, whereas if the patient is fit, we recommend primary cytoreductive surgery and high-grade tubovarian carcinoma presumed to achieve complete cytoreduction. Also in clear cell or mucinous, where we presume to achieve complete cytoreduction. And in low grade, either with no residual or residual less than 1 centimeter. In clear cell or mucinous, with expected residual less than 1 centimeter, you could go either way. And again, this is because we know that these diseases are not particularly chemosensitive, and that's why we've decided to do the table in this way. When it comes to stage 4 disease, we've put yellow boxes, which is both options can be considered. And this is for stage 4A, presumed to achieve complete cytoreduction. And again, it really depends on the status of your patient, at the infrastructure of your center, and only if you can achieve complete cytoreduction. In regards to HIPEC, that's not the topic of this lecture or this talk, and so I'm also then not going to go into detail, but just to include this in our statement regarding this, that for patients undergoing primary cytoreductive surgery, we do not currently have evidence of adding HIPEC, so this should be not be performed outside of clinical trials. Whereas for patients with stage 3, where primary cytoreductive surgery is not feasible and who do not progress during neoadjuvant chemotherapy, HIPEC is absolutely an option in combination with complete or near complete interval cytoreductive surgery in experienced centers with also HIPEC experience. And this is according to the Fandriel protocol. So in conclusion, the goal is cytoreductive surgery with complete gross resection at an expert center with dedicated surgeons and in patients able to tolerate extensive surgery. We need to look at our surgeon skills and institutional resources to deliver optimal care to first do no harm. This is one of my favorite quotes from Blake Caddy, who was, when he gave his presidential address to the New England Society, Surgical Society in 1996. And he said that in the world of surgical oncology, biology is king and selection is queen. Technical maneuvers are the prince and princess. Occasionally, the prince or princess tries to usurp the throne. They always fail to overcome the powerful forces of the king and queen. I invite you to join us for webinars on May 12th and June 11th, where Anna and myself will be moderating together with our experts in regards to the updated ovarian cancer guidelines from ESGO. For those of you who would like to visit Norway in June, we are also again offering our course in advanced cytoreductive surgery with our wonderful faculty. This is a 3-day course, 2 days lecture, 1 day's hands-on cadaveric dissection. So if you're interested, please scan the QR code, and we welcome you all to Oslo. And I hope also, I know it's almost a year away, but to see some of you in London in February 25, 27 next year for the ESGO Congress. On behalf of my team at the Norwegian Radium Hospital and our ovarian cancer surgeons, our team is much larger than this, but these are the women who take care of patients with advanced ovarian cancer. Thank you very, very much for your attention.
Yeah, thank you so much, Professor Gerder, for such an enlightening discussion. And I believe TRUST trial was possibly one of the best designed trials to actually answer this question, whether primary cytoreduction, it is actually the trial which shows the objective evidence that, there's a definite improvement in PFS and a clinically significant improvement in the OS. I'd like to, with the permission of SFS, can I take some questions from the attendees?
Yes.
Okay, so the first question, anonymous attendee, would you like to unmute yourself and ask the question?
I think Dr. Neha, you can ask on.
I think in the interest of time, we have time only for a couple of questions. So perhaps.
Yeah, so this
Neha,
is
just, yeah.
This is a big debate we usually have even when during our conferences, total versus selective peritonectomy in the absence of visible peritoneal disease in stage 3 or 4 ovarian cancer during interval cytoreduction. What is your take on doing a total peritonectomy in an interval setting after it has responded to chemotherapy?
Yeah, so for me, this is challenging, right? It's challenging with the naked eye sometimes to see if this is burnt out disease or if there's still viable tumor in sight. So I would say that I think palpation honestly helps in regards to how the tissue feels. But if I'm unsure, I always send for frozen section. I don't want to do a total peritonectomy on these women if I don't have to. But I also am more than happy to if I should from an oncological standpoint. And so if I'm unsure, I will always send to frozen section and ask my pathologist if there's still viable tumor tissue in the region. And if there is, I will do a peritonectomy of that anatomical region.
Okay, thank you. The second question is by Dr. Albert. What scale do you normally use to assess the preoperative disease burden?
Right. So in regards to preoperative, we use a CT score, the CT score that's developed at MSKCC Cancer Center by Dennis Chi and his team. And we then also look at patient factors, obviously, in regards to that. We are currently looking at using laparoscopic evaluation for select patients, but we're not quite there yet. But at the moment, we use the CT score.
The next question is for Dr. Anuradha. Was any pattern observed in cases where there was a disagreement in pause and MDT?
Okay. In patients who had a disagreement between pause and MDT decision making, it was histology driven. For example, low grade serous ovarian cancers and certain type of histology, despite a higher volume, would go for surgery. And oftentimes we found that they would end up with the major tumor debulking, but we would agree to let it happen that way because there was no other option because the chemotherapy would not work in this subset of patients. And that is one clear-cut scenario. And the other scenarios would be definite discrepancies with regard to identifying very small miliary metastases in the mesentery. So that is something that is beyond the scope of imaging at the moment. And that has happened to us where we decide on cytoreductive surgery, but at surgery it has turned out to be otherwise. It's not possible to achieve that because of diffuse miliary metastasis.
And in the interest of time, one last question. Is there any cutoff PCI for ovarian carcinoma beyond which, even with a CC0 score, there's not much OS benefit?
Well, I think that in regards to that, our data from the ESGO ovarian cancer database shows that there isn't. If you apply even a high complexity surgical score, so if you do absolute maximal surgical effort and achieve no residual disease, there is a survival benefit.
So may I ask you a question, Dr. Gurda?
Of course, yes.
So what percentage of patients in the TRUST trial received bevacizumab? I know it was matched in both cases, but
yeah, I believe it was 65% that I showed on the slide. It was, yeah, I believe
okay.
approximately around 65.
Yeah. Any more questions from the audience?
There are more questions on the Q&A. I think we should complete them. One more from Dr. Albert.
Albert, I can't see this. I have one on medical legal problems regarding training.
I'm happy to take the one in regards to the database.
Yeah, yes, please.
Yeah, so we had a call for projects in regards to doing research from the ESGO database, and we selected, or not we, there was a scientific evaluation committee that selected winning projects. So they're currently ongoing, and our statistical team is working on that, and there will be a new call. We're currently also evaluating how this should be done, if we should have set calls at set intervals, because we've had a lot of interest and various centers and individuals have reached out to us with clinical questions and if they can do these. And I think it is that's why we've generated this database, right? So that we can answer questions that we're unable to answer individually from our centers. So please just follow the ESGO website and any announcements that we make. But at the moment, we're just working on those first initial 9 winning proposals, plus some other just from the core team. And then there will be new calls. But if you have also questions, please don't hesitate to reach out to me, or we have a generic email on the ESGO website as well to reach out in regards to the database.
Right. So I think we've answered almost all the questions unless there's any more question left. So let me extend a big vote of thanks to Professor Gerda and Dr. Anuradha for this wonderful, enriching session. And I'm sure we all have learned quite a lot to take us back to our own clinical practice and reevaluate what we are doing. Thank you so much. Over to you, Dr. Snita.
Yeah, Dr. Snita suddenly had some emergency. I think we can call it a day. It's
Yeah.
been really wonderful. Dr. Kazi?
Yeah, thank you. Thank you, all of us, all of the attendees for joining us for this collaborative webinar. And the most thanks goes to our speakers, Dr. Gada and Dr. Chandramohan. Dr. Chandramohan is one of the world's leading authorities in peritoneal radiology, and we had the privilege of hearing the president-elect of ESGO, Dr. Gada. Thank you very much for taking out time and speaking with us. Thank you to our moderators, Dr. Neha and Dr. Snita. And as always, thank you, Dr. Aruna, for coordinating all of this, curating the topics and the speakers. Thank you very much. And on behalf of SFS as well as Indepso, we'll be signing off and hope to meet you once again in the next session. Thank you very much.
Thank you. Thank you so much.
Thank you.
Thank you.
Thank you, everyone. Thank you for having me. Thanks. Bye.
Thank you.